Thank you again.
You're welcome.
Next speaker will be Professor Roberto Cuaranta. He's the chairman of the Association of Argentina Ultrasonography. 下一位讲者呢，他是来自阿根廷的 Roberto 教授啊，他是阿根廷血管超声协会的创始主席，也是血流动力学在阿根廷和南美洲应用的先驱，所以我们以掌声来欢迎Roberto 教授。
Hemodynamic and echo Doppler basis for treating varicose veins. A brief summary of the evolution of hemodynamics in veins for initial comprehension of CHIVA. I'm Dr. Roberto Cuaranta. I'm a cardiologist mainly, and I have no conflicts of interest. I come from the city of Paraná in Argentina in South America. First of all, I would like to thank the organizer for this forum for the invitation. I'd like to congratulate Dr. Miles, Sofia, and Victoria for having chosen the subject of the hemodynamics of the veins as the title of this forum. I must tell you that we are very lucky to be able nowadays to be talking about the blood circulating in veins. Back in the 70s and 80s, the common belief was that the veins were just conduits where the blood was still or motionless and didn't move at all. Venous hemodynamics and Doppler ultrasound. Echo Doppler is the best tool we have to study vessels, their structure, and the blood circulating inside. Venous Doppler ultrasound, it is not easy to perform due to the pleomorphism of the veins and the vast territory they occupy in the limbs. To all this, we must add the study of varicose veins, which at times can be very complex. For the evolution of this knowledge about the veins and their physiopathology and their hemodynamics, we must thank to Dr. Claude Franceschi from Paris, France, with his innovative ideas, founded in a profound knowledge of the anatomy and the Doppler ultrasound in the vessels, arteries, and veins. And after his experience and knowledge and his creative mind, we have now the evolution of the hemodynamics in the veins. The way to investigate the veins and their functions. But to understand flow dynamics in veins and varicose veins, we must understand how veins fulfill their physiological functions. The venous system ensures a flow unidirectional to the heart with a debit and pressure adapted to the needs of the drainage of the tissues, thermoregulations, and heart repression, which is a concept that we use very much in cardiology, that is the preload, using the heart failure and all thinking about the blood mass that is arriving to the right heart. All these functions are assured wherever the position or the posture of the body and the muscle activity. For the venous function, we have also components that we must be aware of. One is the venous pathways and the other is the pumps. The pumps are cardiac, thoracoabdominal, and valvular muscular. One of the important functions of the veins, this is the surface of the body, are the irrigation of the tissues and the drainage of this irrigation. First of all, in the filling of these tissues with blood through the subaponeurotic and supraponeurotic arteries, through the microcirculation and the little capillaries to the venules, and then the drainage from the venules to the supraponeurotic systems of the veins, through the perforating veins, down to the subaponeurotic veins. This is the drainage of the tissues. That means the very important function of the vein that should be in the conservative idea of them. Another of the important functions of the veins is the thermoregulation of the skin, which is done through all the systems that we have seen in the last slide, plus this situation that can occur when there is some external or internal factor that increase the heat. This is endogenous when you do exercising, or when there is fever, for instances, or exogenous when there is external heat because of the weather or some heat fountain. Then opening the microshunts increase the arterial debit through the venules, the capillaries, then the microshunts open, increase the arterial debit, and increase also the venous debit and the residual pressure. All factors very important to be taken in account in the venous hemodynamics. This means the loss of heat by convection or by eliminating calories, cooling the blood in the superficial of the body. Another important component, obviously, is the venous pathways, which the idea of Claude Franceschi was to divide it or to consider 4 networks, divided in N2, N1, N2, N3, and N4, meaning the networks of the deep veins, like femoral and popliteals, are called network N1. The saphenous trunks, like the greater saphenous vein and the lesser saphenous vein, is called network 2, N2. The network 3 are the saphenous branches that arrive or leave from the saphenous trunks. And the last are the network N4 that are the branches connecting superficial networks amongst them, like between lesser and greater saphenous vein. And on the system also count in important the communicating veins, which are the perforating veins, including the saphenous arcs, which are obviously the main perforating veins at all. This is another crucial knowledge that we have to keep in mind, is the transmural venous pressure, because it's going to regulate us the venous caliber that will lead to the varices and dilatation of the veins. The transmural pressure is composed by internal pressure that is playing a role through the wall of the vein, and is produced by the hydrostatic residual pressure, that is counter external pressure arrives through the tissue surrounding the veins, the atmospheric pressure or the osmotic pressure. Then we'll see in this how the hydrostatic pressure is composed by a vertical gradient oriented from the top to down and the height of the column. And the residual pressure, that is the gradient oriented toward the right heart. So we have the left heart with the blood pressure going through the macrocirculation, exchanging the air substratum in the skin, and then it will be through the microcirculation residual pressure that goes up to the right atrium. In case of valve incompetence, often a closed shunt in the valve muscular pump, the venous insufficiency acts only during walking due to the lack of dynamic fractioning of the pressure column. In this schema, we can see all the variables that can occur during the walking or the standing position, and how the level of the pressure is augmenting, increasing, or diminishing, depending on the position of the body and the walking situation. Here we can see the advantage of analyzing the hemodynamics in the veins with echo Doppler. To the left, the spectral analysis of the Doppler in the reflux through the lesser saphenous vein that is here represented. To the right, we see the deep vein through the incompetence of the valve going to the greater saphenous vein in a huge reflux. To the low left, we see the reflux analyzed with Doppler through the vein in the saphenous vein. And to the right, another huge reflux that you can see with color. All these tools are evident and help to know the hemodynamics inside the veins. So Doppler ultrasound in chronic venous insufficiency is essential to accurately assess, first of all, the patency and continence of the deep venous tracts. Secondly, the origin of the refluxes and the inguinal area at the arc of the greater saphenous vein or the perineal veins or abdominal and other collateral veins. In the popliteal area at the arch of the lesser saphenous vein, of the Giacomini vein, or the gastrocnemius veins. And in the case of perforators, we have to specify the degree of their incontinence and the caliber of them. It's essential to accurately choose the adequate treatment. And in this sense, you have to inform the diameter of the greater saphenous vein, indicating the site of this measurement, generally at 10 centimeters under the groin. If there are dilatations, we have to precise the location, diameter, and extension of the dilatations. We have to specify the location of the lesser saphenous arch in relation to the popliteal fold, and if it arises in a common trunk with the inner gastrocnemius vein, we must indicate if there is a reflux in each one or in both of these trunks, and which is the magnitude of it. If other varicose branches are to be treated, explain their trajectory, diameter, and relationship with the perforators. The diagram of the superficial veins indicating the direction of flow and the location of the perforators, and also the coexistence of arterial disease. Venous exploration, we have to make direct compressions under the probe, mostly performing the cubitus and sitting position, but this is mainly to examine the patient for thrombophlebitis. Meanwhile, when you are investigating and studying a patient with a venous insufficiency, there are dynamic maneuvers, such as the Parana maneuver or the squeezing test, which must be performed in orthostatism. Another concept of the CHIVA cure and the hemodynamic of the veins are the closed and open shunts. This is a case of an open shunt that is produced because of an obstacle in this trunk, venous trunk, that is compensated by supplementary rows. This is called open shunt. The concept of closed shunts is another innovative idea of Claude Franceschi, and he described different kinds of shunts. We are going to talk about 3 or 4 now because of the time we have. The shunt type 1 is when the blood coming from the deep goes through an incompetent valve in the arch, for instance, going to the saphenous trunk. This is the network 2, and going back through a perforator that is called reentry, going to the deep vein or network N1. The closed shunt type 2 is when the escape point is in the network 2 or the saphenous trunk. saphenous main trunk, which would be the lesser the greater. Then goes to a branch that is starting in the saphenous trunk, and the incompetence at the escape point goes through this network 3, through the deep system, through the perforator to the deep system, that is the network 1 again. The closed shunt type 3 is the most common of the shunts. And here we have the escape point from the network 1 to the saphenous trunk, then going to the branch that is incompetent as well, and you get a retrograde flux through the branch and through the reentry perforator to the deep network 1. And 1 and 2 and 3 to N1 again. In this case, which is a variable of the shunt type 3, the escape point is at the network 1 with a reflux through the saphenous trunk through a network 4 that is a superficial, integrating both superficial systems, then goes down to the network 2 or to the saphenous trunk again, to a branch of this saphenous trunk, and going through a reentry perforator to the network 1 and back to the heart. Most venous insufficiencies are linked to a dysfunction of the valve muscular pump. The most common cause is valve incompetence of the superficial veins with closed venous shunts. These are new concepts that we have in order to understand the physiopathology of the venous insufficiency. New concepts that we learn through this physiopathology of the hemodynamic is that the hemodynamic fractioning of the hydrostatic pressure, the venous shunts closed and open, the reentry perforators, and the need for saphenous vein conservation in order to not compromise tissue drainage and avoid varicose recurrences. The hemodynamic and conservative strategy for the treatment of venous insufficiencies, including the varicose syndrome. And thank you very much for your attention. This is a site from my city in Paraná, where we examined many years in a row patients with Dr. Franceschi. And that's the idea of the river in front of the city.
And thank you, Professor Cuaranta, and thank you share with us the beautiful picture of the Paraná. The Paraná River is far from with us, but the Paraná mover is stay with us daily in our daily work. We use it every day. And thank you for introduce several hemodynamic concepts and new concepts for us in your lecture. And Professor Cuaranta has 30 years experiences on hemodynamic diagnosis and CHIVA treatment. So it's a very nice chance to have a discussion with him. Well, let's see our audience and our panels. Do we have some questions or comments for Professor Cuaranta? Okay, 我有一个问题啊. I have a question for you, Professor Cuaranta. We all know that we have lots of shunt 3 patients in our daily work, especially in CHIVA treatment. And how do you manage with the shunt 3 patients, especially those trunk diameter is over 8 millimeter? You know, maybe we should do CHIVA 1 plus 2 at the same time, but this kind of procedure will increase the incurrence rate of this kind of patients. Thank you.
Yes, Nimehao to the audience, and Shishi for your invitation, and Shishi also for your question. Well, the shunt type 3 is the most common of all. And if you have the possibility of re-examining the patient and check again and see the patient back in your office, then you can do first the ablation of the peripheral reflux, and then go, if it doesn't work, to the principal reflux in the escape point at the cross. This is my idea, but the practice is more important than the theory. So it depends on what you have as patients and the possibility of the place where you are practicing. From the beginning, when we started to do CHIVA 30 years, many years ago, here in Argentina, we didn't have all the possibility of calling the patient back to do some second surgery. So mainly we do as a first time the point of escape directly without doing it in 2 times. I don't know if that has answered your question, Victoria.
Okay, thank you. 那 Professor Cuaranta 呢也提到了，确实在 CHIVA 的日常诊疗当中 ，Shunt 3的患者还是占到很大一部分的。那么对于 Shunt 3的患者的处理呢，他还是认为实践的结果更要重于理论。也就是说，我们要根据当地的个体的患者的病情，还有当地的医疗条件的水平，那么来为患者制定一个更加适合于他的医疗方案。所以这是他提到的 ，Practice is much more important than theory. Okay, thank you. I know it's very late in Argentina. Thank you. Stay with us online. Please.
I just wanted to thank you very, very much for your invitation. And first of also, the importance of this concept in CHIVA treatment is the conservative idea of the veins, because I show you all the functions that are so important, and maybe we don't have an idea in mind to keep the veins, the complete surface veins for the drainage, the thermoregulation, and the preload system. So that's what I wanted to point out, besides all the physiopathological concepts that Claude Franceschi has taught us. And thank you again, and congratulations for your Venous Forum. Good luck.
Okay, thank you. Thank you.